So this is a 34-year-old male, came with fever and cough to the A&E, and they wanted to rule out any pneumonia. So a chest X-ray was performed. Over to you.
Okay, this is a chest radiograph, frontal projection of adult patient having history of cough, and query was to rule out pneumonia. I can appreciate that I'm looking at both lung fields. I am in suspicion that there is an area of subtle radiolucency involving the right apical region, which is devoid of any vascular markings.
Don't worry, that's a compound shadow. So I can understand what you are pointing out, but don't worry about it.
Okay, in the rest of the lung fields, I am also there is also impression of subtle slight haze involving the right lower zone projecting over, I think, 11th rib, and in the rest of the lung fields, I cannot make any other significant nodule or metastatic deposits. The both costophrenic angles are unremarkable. Both hyla are also normal. The cardiomediastinum, there is slight. I'm looking at the left heart border. It also seems to be unremarkable. Now I'm looking at my review areas. There is the visualized bones and soft tissues are unremarkable. The spine, there is no paraspinal soft tissue pacification. However, I will, in my routine practice, I will change the window. I will slightly change the window and will look for any paraortic region. And also, I will like to see.
Change the window slightly for you.
Okay, still the significant abnormality only is, there is subtle region of in case of pacification involving the right lower zone, projecting over in relation to the right.
Don't worry about the lungs. Anything else you can find?
In the mediastinum, just below the aorta, there is slight prominence of the pulmonary conus. However, I think it is also projectional. However, in the soft tissues, I can appreciate that there is radio opacity involving the right scapula. There are at least 3 increased density areas involving the right scapular area. So, in my routine practice, I will further inquire about the history of the patient, and also I will suggest CT chest, HR CT chest for further evaluation.
So what are you worried about this finding which you have picked up over the scapula? What are you worried about?
Sorry, if it, I assume that these are not artifactual, so these would represent some pathology related to the joint. It could be due to synovial osteochondromatosis or due to hyperparathyroidism.
CT for that?
No. I will suggest further. I will like to rule out other metabolic disease, and I will also like to see other joints. And if this is the single abnormality, it could be synovial osteochondromatosis, for which I would suggest MRI of the right shoulder joint. for further characterization.
What can you do now to evaluate it further? The patient is in A&E.
I can also like to see the orthogonal view and
What
also
you
the right shoulder
what
joint,
you-
proper right shoulder joint. Okay, in this AP projection, I can appreciate that these increased densities, they are more pronounced, conspicuous in this radiograph. And these are involving the periarticular region. Likely these are favoring synovial osteochondromatosis. And other differentials include hyperparathyroidism, or as the joint space is preserved, so the possibility of osteoarthritis is ruled out. So likely this is a case of synovial osteochondromatosis.
You have
So I
considered
will
you have
sorry?
considered hyperparathyroidism. Why have you considered hyperparathyroidism?
There are some rice bodies, but they are not. I put in the differential.
What happens
There are
in
some.
hyperparathyroidism? How can you explain it? What kind of findings are there in hyperparathyroidism because of which you have considered it in the differential?
There are millet seed bodies. I cannot clearly delineate or explain them, but I have read that these could
Millet
be put
seed
in the
bodies are
differential.
seen in hyperparathyroidism?
Sorry?
Are they seen in hyperparathyroidism?
CPPD, they are seen in CPPD.
Okay, what will you like to do next?
I will inquire about the history of any shoulder joint pain, and also I will suggest a referral to the rheumatologist. And also I will suggest MRI to see any other synovial abnormality.
Over to you. You can ask for mouse.
Sir, I have requested.
Accepted.
Okay, this FATSAT MRI of the shoulder joint coronal images, I can reappreciate that there are multiple hypointense structures within the joint space. They have surrounding high intensity halo, and I am looking for any joint effusion. There is no significant joint effusion. I'm looking at the supra spinatus stand, and it seems to be unremarkable. There is no any Bankart lesion or any Hill-Sachs lesions. Subtle changes in the marrow in the proximal humerus. These could be geographical. So, in summary, in this MRI FATSAT images, coronal images, there is again appreciation of bony increase in low intensity areas in the joint space. So further confirming my diagnosis of synovial osteochondromatosis.
Okay, now regarding, do you see these?
Yeah.
Where are these?
These are in the joint space.
Which joint space?
Surrounded. I can inferior. They are in the infra. They're in the recess of the inferior lunate recess. Scapula, they are also.
Okay, then
So
thank
these
you.
are in the subcoracoid bursa.
Yeah, that's okay. Thank you.
Thank you.
Right. So this case was synovial chondromatosis of the right shoulder. It was a what we call an observation film where a subtle asymptomatic or incidental finding was picked up on incidentally on a chest X-ray done for some other clinical reason. Now here we let's revise quickly synovial chondromatosis. It is a benign monoarticular disorder, unknown origin. Basic pathology is that there is synovial metaplasia and proliferation. Then what happens is that the prolif- the proliferates, they get detached and they go into the joint space. They indirectly become loose bodies. Initially, they are cartilaginous, then they can be, ossified over time. And so that is why the signal intensity can be variable. In long-standing cases, the signal intensity will be just like bone marrow, and it will be high on T1. Uh, Not all of them are ossified. In the case which we saw, it was not ossified, though I did not show you T1 weighted sequence or a PD weighted non-saturated, fat saturated, but I'll show you subsequently. Age is usually 4 to 5 decade. The joints, knee is most common, 70%, hip 20%, but elbow and shoulder are other joints. Radiological appearance is variable according to degree of calcification. When loose bodies occur, they produce, mechanical problems, and usually there will be secondary osteoarthritis. So when you describe it, this should be part of your pertinent negative or positives. Look at this patient. This is ankle osteochondromatosis. And this is, you can see that now OA of the ankle joint has developed. The patient is only 20 years old. These are other examples, two different patients. This is in elbow and this is in knee joint. So good, well done. You picked up the cases, but a bit of fine touch, your differential diagnosis, hyperparathyroidism cannot cause that. Please remember. And if you do that kind of a mistake, then the examiner might, go to it just to point out that you were wrong there. Otherwise, anatomy is critical, and you did mention, ultimately subcoracoid bursa. Yes, it was subcoracoid bursa. So that was picked up well. Now, let me go through the case. So it was a classical incidental finding. You can see these projecting over the scapula, which was well picked up by the candidate ultimately. And then ask for the simplest next test, which is a common sense test. Ask for a X-ray and which will confirm the diagnosis. Say if there is any secondary osteoarthritis or not. Maybe a bit of lipping is there. Maybe early glenohumeral OA is developing. As far as this was all picked up, this is a PD fat saturated sequence where the findings were well picked up, and ultimately this was my question, where is it? So we don't have a T1 weighted sequence, but we have got a PD non-fat fat saturated sequence where the bone marrow is similar to T1. And we can see that the loose bodies here are low signal, still not ossified, still not equivalent signal to the marrow. So please remember that in long-standing cases, it might be equal to the marrow. Okay, well done, candidate one. Next case for you. Now, this is a 51-year-old male. The patient presents with a small midline upper neck swelling. They did an ultrasound which did not characterize it. So they asked for an MR of the neck. Midline, upper
yeah.
neck. Yeah. Over to you.
Okay. Okay, these are contrast enhanced T1 weighted images of the neck.
Can I stop you? Why did you say contrast enhanced?
So I can say vessels, few.
Do you see
along
vessels in contrast enhanced scan? Look at the CSF in the spinal canal.
Okay. So this is hyper. Okay.
Please
Okay,
continue.
T2. This is T2. Sorry, this is T2. Sorry.
Okay, let me ask you a question. What sequences are done for soft tissue of the neck?
The T2 fat set, and if contrast is used, then fat set T1 weighted, post contrast fat set T1 weighted.
Sure is a better sequence than T2 in neck, but if you say T2 fat set, it's fine. But this is a stir sequence. Okay, over to you.
Okay, in this, I assume this is a single slice image.
No, you can scroll it.
Okay, I was finding difficulty. However, I could see pathology in this image. Sir, I can again request. I think a remote control request. I have again put.
Okay, it is with you.
Okay. So these are T2 weighted axial MRI images of the neck. I can appreciate that in a patient having swelling in the neck region, there is a mixed intensity, predominantly hyper intense region in relation to the posterior aspect of the tongue. I'm going down and I'm looking for the thyroid gland. The thyroid gland also is in its normal bed, however, shows slightly mixed intensity parenchyma. I'm looking for any enlarged lymph nodes. There is no significant lymph nodes.
Can I stop you? I am interested in a midline upper neck swelling. Just concentrate, midline upper neck swelling. That was the clinical.
Okay. I think there is also focus of high intensity along the just beneath the skin. Also, this was I could appreciate another focus of mixed intensity in the posterior aspect. So this could be ectopic thyroid tissue in the retroglotic region.
Madam, where you are pointing out, that's the uvula. That's a normal structure. That's nothing. So just concentrate on the other finding.
Okay, the both thyroid glands are normal. I could see small hyperintensity focus just beneath the skin, right over here. Sir, can you see my arrow?
Yeah.
So I could see only the significant finding. I could see there was hyperintense.
So what can it be?
Sir, it could be some again the focus of some thyroglossal cyst or some midline brinkel cap cyst, or it could be some sebaceous cyst.
Okay. Look inside the larynx. Do you find anything in the larynx?
Yes, there is also air containing structure, low intensity structure along the paralaryngeal space on the right side. It is causing slight indentation of the vocal fold and slight indentation of the air passages. So it could be laryngocele. I will also confirm it on the other views in the coronal views, but likely this is air containing structure is laryngocele along the right side. So I will inform the findings to the referring physician and will suggest referral to the ENT surgeon for further evaluation. Hello.
So what is your conclusion?
In summary, in this patient having swelling along the anterior aspect of the neck, I can appreciate a hypo-intense oval-shaped structure. Likely it is containing air along the right paralaryngeal space, causing indentation of the laryngeal air passage and a slight displacement of the right focal cord. So this likely represent laryngocele.
And the patient presented with a swelling.
A large laryngocele. There is also extending along the right side of the spaces.
Okay, thank you. So this is case 2, and on case 2, I will do a bit of teaching. So a bit of anatomy there. Now, there were two pathologies in this case. One was a thyroglossal duct cyst, and then there was an internal laryngocele. Now, as far as larynx is concerned, two pathologies. Larynx is a difficult one for the exam, but laryngocele is one, and you should have some idea about tumors. It's a rare case, but if you want to learn anything in larynx, these are the two things which you should learn. There have been cases of carcinoma or post-surgery appearance of larynx, etc., which have come in the exam. And laryngocele has also come in the exam. So you should have clear-cut idea, and I'll repeat and revise the anatomy with you right now. So laryngoceles can be air-filled or they can be at times fluid-filled. We'll come back to the theory part of it. Please remember, they can be confined within the larynx, and when it is confined, we call it internal laryngocele, and if it herniates through the thyroid membrane, then we call it external. So you will see combined, intra as well as extra laryngocele. And there are some occupations in which you see them more often, like glass blowers and people who play wind instruments, etc. Key clinical point is that whenever you see an incidental laryngocele, look carefully to rule out any associated tumor. It is very rare that a laryngeal tumor will be diagnosed on imaging. Usually it is diagnosed clinically and then they do imaging. Having said that, in your exam, it should be your pertinent negative or positive for the examiner. because obstructing tumor is another thing which can cause a laryngoscele. We'll come back to the concepts and the anatomy. On the other hand, thyroglossal duct cyst is a very common and important exam case. Please remember here, anatomy is critical and embryology is critical. I'll show you a diagram in which this thing will become clear. That basic concept is that the thyroid gland actually, embryologically speaking, it starts, the pyramidal lobe, it start developing at the floor of the tongue. There is a foramen cecum there, and from there, thyroglossal duct, it extends to the pyramidal lobe of the thyroid, takes it or descends it down into the neck. After birth, what happens is that the thyroglossal duct, it involuates, but sometimes that does not happen completely. And later in the life, it can present as cysts. At times, it can become infected. And please remember that it's not a must that they always will occur or you will see them in children. So the patient might not be a PEDS group patient. And I've seen many in my career where even in 60 years old, I've seen it happen. And the key point is anatomy. So that is the key point. And so you should also be worried about secondary infection. Look at this diagram, and it tells you the embryology. So this is the foramen cecum. And when the thyroid gland is, or the thyroglossal duct, it descends down, either anterior, posterior, or through the developing hyoid bone. So hyoid bone is here. It will always be midline. Remember that. Look at this diagram. So this is the thyroid cartilage, and superior to that, this is it. And it can be any place in this. Look at this, a big one. It's an adult patient where this has infected, and you can see rim enhancement. You can see that. So the point is that anatomy is the key, and in head and neck, anatomy is the key. You know where the lesion is, and everything else changes. So what happens is that, look at this CT scan, which is a 4-year-old. Now we are close to the root of the tongue, and you can see this is the hyoid bone, and you can see this cyst here. And infrahyoid, just after the hyoid, it will extend either to the slightly off midline, either to the left or right. Key point is that it will always be sitting on the strap muscles. So these are the strap muscles, and it will be sitting on it. And it is going all the way down, and then comes the thyroid gland proper. So when it enhances, and on a CT, this is enhancing, of course, clinically also, this was infected. So this is infected thyroglossal duct cyst. What is laryngoscele? Larynx is a difficult part of anatomy, and many people find it difficult. And many people don't even report cases of larynx in your day to day. So I'm going to go through the anatomy once again. And I'm going to spend a bit of time on this case. What is laryngoscele? Laryngoscele is dilatation of the saccule of the laryngeal ventricle. Dilatation of saccule of laryngeal ventricle. So what is ventricle? So I will show you in the subsequent slides. But basically, the saccule itself is a mucosa-lined pouch that arises from the anterior aspect of roof of the laryngeal ventricle. Roof of the laryngeal ventricle. So there is a pouch there, which is lined by mucosa, that is known as a saccule. And when it is dilated by air, it can be dilated by fluid at times, and when it will become infected, it will, you call it a pyolaryngoscele. So that can also happen. It is unilateral in vast majority of cases, usually thin-walled fluid or air-filled lesion in paraglottic space. Please remember that communication with the laryngeal ventricle might not be always identified. So that's an important point to remember. When it extends beyond the thyrohyoid membrane, we call it an external laryngocele. So look at this one. It is passing through the thyroid membrane and part of it. Of course, these patients will present not incidentally, but they will present with swelling. What is the etiology? Look at these, musical instruments. Look at this glass blower. And so excessive coughing can be it, but other than that, playing wood, uh, wind, brass instruments, glass blowing, obstruction or obstructing tumor, this is very important. And case reports have said in childbirth also, after childbirth. Now, uh, whenever you look for you look at a laryngocele or you pick up a laryngocele, you must rule out an underlying tumor. And this, in your exam, you have to impress the examiner by saying that I'm looking for any underlying malignancy. So most of the times they are asymptomatic. Our patient was asymptomatic. Rarely they will cause sore throat, dysphagia, stridor, neck lump, or airway obstruction. Now, this is a repetition of what I have told you, internal, external, mixed. So anatomy. Now, as far as revision of anatomy is concerned, uh, in this area, we have got the pharynx and the larynx. Now, pharynx has got three parts, the nasopharynx, the oropharynx, and the hypopharynx. So posterior to the nose is the nasopharynx. This is the uvula. This is the oral cavity. Posterior to the oral cavity is the oropharynx, and posterior to the larynx is the hypopharynx. Some anatomy books also use the word laryngopharynx, which is the same thing. Please remember that hypopharynx then is in continuity with the esophagus, and esophagus actually begins at C6 level, C5, C6 level. Now, anteriorly is the larynx. Now, larynx has got cartilages which provided a hard exoskeleton. The lid of the larynx is the epiglottis. So here is the hyoid bone. This is the epiglottis. And when we eat or drink, then it covers the lid of the larynx, and so that things don't go into the bronchial tree. As far as cartilages of the larynx is concerned, we have got the epiglottis, this is the thyroid, and this is the cricoid cartilage. I'll come back to the cartilages. Inferior to the cricoid cartilage is the trachea, and the thyroid gland is sitting here, if you see here. Now, these are a revision of the cartilages. This is a frontal view and this is a posterior view. So in frontal view, the largest cartilage is the thyroid cartilage. This is the Adam's apple. All of you can actually palpate it on your neck. So this has got a lamina and a lamina. Superior to that, here is the hyoid bone. And this is the membrane we were talking about, thyrohyoid membrane, which is in between the thyroid cartilage lamina and the hyoid bone. And external laryngocele actually goes beyond it. An internal one remains confined inside. Inferior to the thyroid cartilage is this cartilage, which is the cricoid cartilage, and then comes the trachea. Now, if we look at it from the posterior side, we can see the epiglottis, the lid there, and we have got the hyoid bone, and we have got the thyroid and the thyroid cartilage. Forget about these processes, anterior and posterior, these also belong to the thyroid cartilage. This is the posterior part of the cricoid cartilage. On the cricoid cartilage sit the arytenoid cartilage. And arytenoid cartilage is the cartilage where the vocal cords are attached. Now, this is a sagittal cut diagram. So here you can see that this is the cricoid cartilage. This is the posterior part, which is in a craniocaudal dimension. It is thicker. Anterior part is smaller. Please remember that cricoid cartilage is the only cartilage which is a complete ring. So this is a complete ring, and this is the only cartilage which is a complete ring in larynx. On top of it is the arytenoid cartilage. This is the vocal process of the arytenoid cartilage where the vocal ligament is and the muscles will be there. So this is the level of the vocal cord, the true cord. And then the thyroid, and then the epiglottis and the hyoid bone. Now, this is a view from above where just to point out that this was that vocal ligament and these are the muscles, which of course on radiology, it is very difficult to see them. They are so small, but this is the type of airway, a boat-shaped airway, which you will see on imaging. This is the level of the true cord level. Now, this diagram is key diagram in which will tell you a few more words to add to your vocabulary. Please remember, we divide the larynx into the glottis. Glottis is the true cord level. Anything which is superior to the glottis is known as supraglottis. Anything which is inferior is known as infraglottis level. As far as tumors are concerned, when we diagnose tumor, we tell the clinician if it is glottis, glottic or supraglottic or infraglottic, and you will also see tumors which are transglottic. Portion of it will be at the true cord level and superior or inferior to it. Now, on this coronal, key point is that this air space, in the upper portion, the supraglottis is known as vestibule. Here, there are mucosal folds. These mucosal folds are prominent folds, and they are known as false cord. On imaging, it is very important to differentiate between the false cord and the true cord level, and I'll show you. Now, lateral to that, these are the laryngeal ventricles, right and left ventricle. And please remember, in the ventricle, because in an AP dimension, there is extension of the ventricle, is a structure which is known as saccule. And that saccule actually, so this is the saccule we are talking about. This is mucosal lined pouch that arises from anterior aspect of the roof of the laryngeal ventricle. And so in the ventricle is that pouch which will dilate and will, because of air or because of fluid. And many a times you will not see the connection between that dilated laryngocele and the ventricle. So this ventricle should be in your vocabulary. Now, this diagram once again tells you how do you divide into glottic, supraglottic, and infraglottic levels. Now on that skeleton of cartilage, add a bit of soft tissue. So if you see here, this is the cricoid cartilage. On top of the cricoid cartilage is the arytenoid cartilage, and then this is the true cord level. Now, one key point in laryngeal imaging, particularly on a CT scan, is that just imagine that a slice of CT is passing like this, in an axial slice is passing like this, where my mouse is. And this will pass through the arytenoid cartilage and then the cricoid cartilage. key point, take home point to remember is, and in the exam, if I show you a CT scan, I will actually ask you to point it out. Where is the level of the true chord? And the formula is that at a level where the slice passes through two cartilages, that is the level of the true chord, because it will pass anteriorly through the arytenoid and then the cricoid. So I'll come back to this point. Now, some critical mucosal folds. From the arytenoid cartilage, there is a mucosal fold which goes to the epiglottis. This is the aryepiglottic fold. Please remember, anything this side of the aryepiglottic fold is the supraglottic larynx. On the other side is the laryngopharynx. So this is the boundary. Very, very important concept. Now, this is the epiglottis. In the midline, there is a mucosal fold here, which is known as glossoepiglottic fold. Look at this word, glossoepiglottic. What does it mean? It attaches to the tongue. Glosso means tongue, and then it goes to the epiglottis, glossoepiglottic fold. And this on imaging is very well seen. On the right and left side of the glossoepiglottic fold are the valleculae, which we see on even barium examinations. Laterally is a pharyngoepiglottic fold, and superior to that will be the oropharynx. This is the hyoid bone. Another key point to remember is that there is fat anterior to the epiglottis. This is the pre-epiglottic fat. Now, once again, a repetition that true chord is this level where there are two cartilages. This mucosal fold otherwise is depicting the false chord. So don't confuse the false chord with the true chord. And the formula is to look at two cartilages. I'll show you on a CT scan to consolidate this concept. Now, this anatomy has been asked in the exam, and this you must know this anatomy. This is a barium examination, barium solo examination. And on a barium solo examination, if you place yourself here on a axial slice, you can see that this is the epiglottis. So the epiglottis is here. And aryepiglottic fold. These are the aryepiglottic fold, which is here. This is the glossoepiglottic fold, which is this midline structure. On the right and left of the glossoepiglottic fold are the vallecula singular or valleculae. And these valleculae on a barium lateral view, they are projected anteriorly. And on a AP view of a barium, they are this right and left. And this indentation where I'm pointing out is the glossoepiglottic fold. Extremely important anatomy which has been asked in barium of the neck in the past. Posteriorly is the piriform sinus. Piriform sinus. So this is posterior to the glossoepiglottic fold, which is depicted here. So this is the piriform sinus. Piriform sinus is by definition a part of the hypopharynx or the laryngopharynx, whatever word you want to use. So please remember, final take home point, valleculae are anterior and piriform sinus is posterior. Piriform sinus are part of the hypopharynx, and this one is the supraglottic larynx. Another concept about laryngeal cartilage is that laryngeal cartilage in a child will be, just cartilage, but as they age, they can ossify. And on a plain X-ray, you can see ossification. On a CT scan, it will be better seen because it is ossified. A young laryngeal cartilage in a young patient, you will not see very well. So here, let's go through these axial slices. So this is the epiglottis. This is the glossoepiglottic fold. A bit of fat is coming into view, and this is the hyoid bone. Posteriorly, this is the piriform sinus. Piriform sinus is the posterior wall of the the hypopharynx. Look at this slice. It is passing like this, and you can see this glossoepiglottic fold, and this is velicula, piriform sinus, and this is the hyoid bone. Slightly more inferiorly, we can see more of, now the slice is passing through the hypoepiglottic ligament, which is within the fold. There will be more fat visible. Here you are. Look at this slice. This is the slice, and you can see this hypodense. More fat is there. This is the superior-most portion of the supraglottic larynx, and piriform sinus. Then we are going, distally. And here, look at this. Look at this slice. This slice is passing through the level of the false chord. And this is the type of airway you will get. This is also a take-home point. Look at the airway. It's not boat shape. It's rounded. So don't call it when the examiner asks you that this is the true chord level. This is false chord level. Now this is the true chord where arytenoid cartilage is here, cricoid cartilage, arytenoid, cricoid, and this is the ligament, and these are the muscle. Look at the airway. The airway is boat shape, and this is, one part of anatomy. If you ask me, just tell me one thing about anatomy, the radiological anatomy of larynx, I will again emphasize on this. Develop your eyes to pick up the true chord level, and the formula is that you will see two cartilages, arytenoid and cricoid, and then the airway will be boat shape, and this is passing through that. So please remember that this boat shape might not be visible to you when you have scanned a case, because it all depends if the patient, is phonation. Classically, when we do a CT of the larynx, we call it the larynx protocol. What we do is we ask the patient, it's a two-phase study. In phase one, we ask the patient to breathe, shallow breathing or phonation. So we ask the patient to produce a sound like ah. So the patient is doing this as we scan, and you will get this kind of picture where there is abduction of the vocal cords. Then we do another phase in which we ask the patient, hold your breathing. When the patient will hold the breathing, you will get this kind of airway because they are adducted. And still you can see this cartilage and this cartilage, you are at true chord level. So in your day-to-day practice, many a times because of this technicality, you might not see the boat shape. Just inferior to the boat shape, then comes the cricoid cartilage, and this is posterior, and then after that we go into, so this is, look at the airway, it becomes bigger and it becomes rounded. This is the cricoid cartilage, and then ultimately we reach the thyroid gland, which is here. So this was a recap of the anatomy of the larynx, which I believe that many people find it very difficult. So it was a good idea to repeat it today. Now this is thyroid, just to give you an idea, thyroid, cartilage, and this is the thyroid gland, and this is the cricoid cartilage. So this is a case of a laryngocele, another case I mean to say, where you can see what is happening. So as we come, inferiorly, portion of the laryngocele has gone through the thyroid membrane, and this is portion of it is external. It's not confined inside. So this is a mixed type of laryngosele, internal as well as external. So other pictures and examples, this one is infected. You can see that there is some enhancement, but there is nothing, significantly. So if you see, look at this diagram. This is the ventricle and it communicates here and goes out. It can be fluid filled, which is depicted here. If it is infected, then of course, we will clinically speaking, we call it then a pyolaryngosele. Now, uh, so as far as head and neck is concerned, let's revise. Uh, let's revise what sequences we do in head and neck MR. In head and neck MR, we do stir sequence T1, and then we do fat saturated T1 and post contrast fat saturated. So these are the usual. So the T2 you are referring to, by definition, it's fine fats, but we use a stir. So this is a stir sequence. On this stir sequence, first of all, look at the clinical. The clinical was that there is a midline swelling. So there is a swelling here. So there is a fluid containing structure. Now, as I go superiorly, this is the tongue. And just when the tongue is finishing, you can see this fluid containing structure. And so this is the thyroglossal duct cyst. Anatomy is the key. It is sitting on the strap muscles here. It is sitting on the strap muscles. And even here, you can see it. It is on the strap muscles. And so sometimes it will extend down. So this was a thyroglossal duct cyst. I did not show more sequences than this, but basically we have got a post contrast where there is some minor enhancement of it, and possibly it was mild infection, but there was no abscess formation. On the other hand, let's concentrate on the laryngosele. Now, if we go superiorly, so here is the tongue. Now, as we are going inferiorly, this is the epiglottis. And you can see that the superior-most portion is going all the way to the the commencement of the supraglottic larynx. So it is all displacing it laterally. This is the piriform sinus on the contralateral side. Here the piriform sinus is compressed. As we go inferiorly, of course, it becomes even larger and is compressing everything to the other side. It doesn't go outside the confines of the thyrohyoid membrane. As we come inferiorly, we can see this boat-shaped airway. So this is paraglottic region. And here you can see just the inferior tip of the laryngosele. And then this board changes to a rounded airway, which is the cricoid. I also have got a CT scan for this patient. Actually, later on, a CT neck, chest, abdomen, pelvis was done for some other clinical issue, but I just want to quickly show you this, where we can see as we are coming, this is the tongue. So this is the epiglottis, and this is the glossoepiglottic fold, vallicula. Here, this is the piriform sinus. This is the piriform sinus. And this is the supraglottic extension of the laryngosele. So if you get it in the exam, you will get marks because of your description. And the examiners will ask you anatomy, what is happening here, which part of anatomy are you here, and things like that. So this is still the supraglottic larynx, and the superior portion is extending here. So this is the piriform sinus, this is the piriform sinus. As we come inferiorly, so now we are at the level of the true cord. Here there are two cartilages. Unfortunately, because of artifacts in this patient, the cartilage are not very well seen, but then this is the boat, and then we come to the cricoid cartilage level. Okay, so this was a longish case for teaching, but I thought that it will be a good idea to revise laryngeal anatomy. So don't worry, rest of the cases will be less teaching. So let's go to candidate one. You are still with us.
Yes, I am here.
Okay, this is your last case. Now, this is a 37-year-old male. The patient presents to A&E with acute respiratory failure type of symptoms, fever, very toxic, horrible breathing. So over to you.
Okay, this is a chest radiograph, frontal projection of a critically sick patient. I can appreciate that there are fluffy airspace shadows involving almost all the zones of bilateral lung fields. And there is also saluting of the bilateral cardiophrenic angles. The left costophrenic angle also is blunted. Um, I cannot see any obvious pneumothorax or pneumomediastinum in this case. The visualized bones and soft tissues also seem to be unremarkable. So in summary, in this critically sick patient, there is evidence of widespread areas of um, fluffy airspace shadowing involving almost all of the bilateral lung zones. So I can put differentials in this case. These could be due to alveolar hemorrhage, or this could be pulmonary edema. Other differentials include atypical infections, acute respiratory distress syndrome. I will inform the findings to the referring physician and will suggest referral to the pulmonologist team for further management. Also, this patient needs monitoring of the oxygen saturation as there is widespread disease. And if clinically, after stabilization, the patient also needs further evaluation with the HRCT chest.
Okay, we did a CT. Over to you. You can ask for the mouse.
Okay.
You want to see the...
Sir, I have requested.
So I'll give you just 1 second. So I've given you the lung window, and when you will ask, I will give you the other windows. Over to you.
Okay, these are lung window axial sections of the same patient. There are bilateral areas of airspace specifications in the perihilar region forming a bat wing appearance. Also, I can appreciate that heart is mildly enlarged, and the pulmonary trunk was also looking slightly prominent. There is also evidence of bilateral pleural effusions. Fluid is also seen in the right horizontal fissure. So likely this is a case of cardiogenic pulmonary edema. There is slight sparing of the anterior segments and extreme apices. So I will inform the finding again, will suggest referral to the cardiologist for further management. Also, I will suggest echocardiography after stabilization of the patient. This patient needs a course of diuretics and follow-up imaging.
Would you like any other window?
Yeah, mediastinal window as the contrast enhanced scan is performed. So in this contrast enhanced examination, there is impression of prominent pulmonary trunk. I'm looking for any embolism pulmonary in the branches.
Don't worry about PE. There was no PE. Please continue.
Okay. I could say there is pleural effusion, bilateral pleural effusions, and the heart chambers, they are markedly enlarged. The right atrium, especially the right atrium, is markedly enlarged. Um, in this mediastinal window, the significant finding is prominence of the pulmonary trunk and also the um, enlargement of the right atrium.
Any other window you want to see?
The pulmonary window specific.
Okay, then give me your conclusion.
So, in summary, in this patient with cardiomegaly and Batwing type appearance of the consolidations or areas of its specification with bilateral pleural effusion, this likely is a case of cardiogenic pulmonary edema. However, other differentials could be pulmonary hemorrhage, or it could be due to respiratory distress syndrome.
Okay, thank you. Thank you. This is a case of sickle cell disease who has presented with acute chest syndrome. And I'll show you the findings subsequently. But basically, just to go back to the basics, sickle cell disease, of course, is a hereditary, hemoglobinopathy, which manifests as multi-system ischemia and infarction, as well as hemolytic anemia. So the point is that people, this is the pathophysiology of it. This is a very good article from Radiographics. If you want to read it, take a picture. I think it's available free of cost. The reference is there. But what people forget in the FRCR, in your day-to-day, that the point is that you think that sickle cell, I will just look for bone, I will just look for spleen. There are so many things which happen with sickle cell and the manifestations of it. And so if you see here, pulmonary, just concentrate on pulmonary. Pneumonia, acute chest syndrome, chronic lung disease, embolism, infarction. Basically, what is happening? Basically, what is happening is this is what is happening. Ischemia is happening. There can be hemolytic anemia, there can be infarctions, and because of that, so many other things happen. You see, this pathophysiology tells you everything. I don't have time to go through that. But key point for you to remember is that don't think that sickle cell will just, I'll just look for bone and I'll just look for spleen and things like that. So these are the musculoskeletal abnormalities. Then genital, gastrointestinal, and I think I've shown you cases with gastrointestinal. Then renal, then splenic, then biliary, and then also brain, which is important. Brain is also important. So there are findings in the brain which the patients will present with that. So this is acute chest syndrome. If you radiopedia it, sickle cell manifestations of respiration in respiratory system, it will tell you acute chest syndrome. These are, of course, acute. And do you see this? Acute chest syndrome is the leading cause of mortality. Can you imagine? Many of the patients of sickle cell disease, when they die because of this. And these are the various things which happen, pneumonia and infarction and all of this. And even look at this one, rib and sternal infarction causing atelectasis from splinting, because the pain is so terrible that the patient is not taking deep breaths. Now, if let's go back to the case. So till this is fine because the findings were totally non-specific. Then candidate one, I had to actually nudge you to ask for other windows. And then there was a very leading question, do you want to see anything? And please remember that in your day-to-day practice, what do you do when you report a CT of the chest? There is absolutely no concept that you just do, this was a contrast enhanced, you just see the lung window. You do a mid-sternal window and then you have to see the bones. You have to. And this was a critical mistake which did because of which you could not make the diagnosis. Now this is hanging somehow. What happened? Okay, now it is scrolling. So on here, everything else, of course, the candidate picked up, dilated pulmonary vein, but there was no, in fact, embolism. So I did not want to waste time on that. One thing is very interesting in this. If you see, this is the stomach. And do you see that there is a spleen here, though it is not calcified, but it is very small. Look at this kidney. So there is a spleen there at the edge of the film, which gives you a bit of a hint. But there is no need of a hint if you go to the bone window, and everything speaks itself. Look at the humeri, and look at all the bones, and look at the sclerosis, and look at the ribs, look at the spine. And if I show you a sagittal, look at this classical vertebrae of sickle cell. So that was it. But the key thing was to ask for the adequate windows. Now, candidate one, thank you very much.
Thank you, sir. Thank you.
Candidate two, are you with us?
Good evening, sir. Can you hear me?
Yes, I can hear you. So all set, ready?
Yes, sir.
Okay, here you are. This is a 17-year-old male, came to A&E with cough. So an X-ray was done.
Okay, so this is the chest X-ray frontal projection of a 17 years old male. In this X-ray, I can appreciate that there is a deficiency of clavicle. I cannot appreciate it clearly. I believe the first, if you can see the screen, I think this is the first strip. And maybe I would like to see on any other window. And also, I can appreciate that the aortic knuckle is not very prominent where it should ideally be. So if I can change the window, or if I can see any other previous study.
Sorry, you are interested in looking for what? Change of window means? So I've changed it
Sir,
slightly. Is it for you?
Sir, I'm concerned about two things. Firstly, I cannot appreciate the clavicles. Secondly, there is a prominent spine of scapula on the right side. And also in the aortic knuckle is not seen in its normal position, and the descending aorta shadow on.
Aortic knuckle. Regarding the clavicles, you have picked up a finding. What do you think is happening?
Sir, I believe that this is a case of cleidocranial dysostosis.
And why do you say that?
But, sorry,
Why do you say that?
sir, because I cannot see the clavicles.
Okay, so what is your differential?
Sir, my differential is that there are some other syndromes as well in which I cannot, in which clavicle is not seen, and maybe pycnodysostoses or some, I don't remember now, but there are a few other rare syndromes in which absent clavicles are seen. So I would like to screen whole of the bones, hand, shoulder, and lateral view of skull, spine, lateral view, lumbosacral to
And
see
how do
any
you
other.
differentiate between cleidocranial dysplasia and pycnodysostosis?
So pycnodysostoses has a sclerotic, it is a sclerotic disease basically, and moreover it has short third and fourth metacarpals, plus there are yes, basically the sclerosis is there. And if there is a unilateral on the right side, I can think of Springel's shoulder, but both of them are showing almost similar views, and the humeri are subluxed superiorly as well, most likely due to the absence of clavicle. I would also like to count the ribs in this patient and would like to see the vertebrae for any hemivertebrae or any associated anomalies, because it has an association with a lot of other bony abnormalities.
We have got only one other X-ray for this patient, and which is just 1 second. My software is, this giving me issues. Now you've got this X-ray. So we've got only one more X-ray for this patient. Over to you.
Okay, so this is X-ray pelvis and femur frontal projection of the same patient. And in this, I can appreciate, sir, you mentioned that the age was 17 years.
Yeah.
So for a 17 years old, bones are showing a little bit delayed ossification. And there is, I would also like to see the vitamin C, vitamin D levels of this patient, because I can appreciate some metaphyseal sclerotic areas, and there are also some swelling, some soft tissue swelling bilaterally uniformly around the knees. The acetabuli are a bit horizontal in shape. So I still believe that this is cleidocranial dysostosis, but I would like to see I would recommend vitamin C, vitamin D levels to see any associated dietary deficiency in this
So in
patient.
this case, in this pelvis X-ray, what is the finding which you have still counted cleidocranial as your most likely diagnosis?
So there are prominent sciatic knot, and there is a horizontal acetabular roof.
Okay, thank you. So you did well, but a bit of confusion was there, which now I'll clarify when we will go through the case. So you did initially well, but there were a few things which you got a bit confused, should I say. So it is cleidocranial dysplasia. This is what it is. And interestingly, this patient was a 17-year-old, and this is how it happened in the real life. We did not know this patient. It was not our hospital patient, came to A&E, and then it was picked up as an incidental finding. What was picked up, as the candidate picked up very well, that there was complete absence of the clavicle bilateral. Complete absence can happen in cleidocranial dysplasia. It can also, the differential diagnosis will always be pycnodysostosis, as the candidate pointed out. But you should have a clear-cut idea about the differentiation between the two. So in cleidocranial dysplasia, what is happening is that basically, midline central ossification is lacking. So clavicle is one of the findings, but another finding in the midline is symphysis pubis. And then in the skull, Wormian bones delayed ossification can happen in both of these conditions. However, in pycnodysostosis is a sclerotic bony dysplasia. So there will be sclerosis, and that is a differential between the two. Another thing is mandible. Candidate did ask for a skull, and I did not have a skull, but in this particular case, skull was not important for the patient was 17 years old. In a child, you must ask for skull. In pycnodysostoses, the mandible is small, it is obtuse. In cleidocranial dysplasia, the mandible is normal, though rest of the facial structures are smaller. So, and then acroosteolysis. Acroosteolysis does not happen in just three bones, three digits. It can happen in every digit, and this is regarding pycnodysostosis. You don't see it in cleidocranial dysplasia. So, widening of symphysis pubis, and you will see that how widened this one was. And this is also important differential diagnosis. These are the measurements. 7 years old, it decreases to 8 millimeter. Poorly ossified cartilage. This is the reason. And this is pycnodysostosis as well as cleidocranial. Both of them are will cause it. Now, this is another case of cleidocranial dysplasia where you can see that the clavicles are missing bilaterally. The candidate did well where was concerned about the scapulae. Basically, what happens, but it did not happen to a great extent in the case which I showed you. But in one of the finding is that the glenoid is small and the scapula can be high riding, but it is not classical Sprengler shoulder type of abnormality, but clavicle scapula and the glenohumeral joint will be affected. Now, this is cleidocranial dysplasia where other than these findings, if you see the skull, you can see still Wormian bones. What are Wormian bones? So Wormian bones are bones within the sutures. They should not be there at this age. Look at this lateral X-ray. You will see that the facial structures, facial skeleton is small. But look at the mandible. Mandible is normal and has got an angle. Look at the pubic symphysis, and there is a huge gap there, just like the case which I showed you. I'll come back to our case. So this is another example where in a babygram you can see that clavicles are missing, and look at look quite hypoplastic type of scapulae and the glenohumeral joint, and then look at the Vermian bones. Look at the Vermian bones which are inside the sutures, and look at the clavicle. Sorry, the mandible looks fine, and then the symphysis pubis is widened. So in pycnodysostosis, if you see the bone density is increased. This is a Wormian bone sitting inside the suture. Look at the bone density. Look at the base of skull, and it is increased. Look at the margins of the orbit, and it is very sclerotic. And then see the facial skeleton is small, but look at the mandible. And mandible is small. It has got an obtuse angle. So look at the mandible here in cleidocranial dysplasia. So, and then in this particular case, there is acroosteolysis. This is in cleidocranial dysplasia. Please remember that sclerotic bony dysplasias are a spectrum. And all of these, most of these, should I say, are very important for the exam. They have come so many times. Osteopetrosis, pycnodysostosis. Diaphyseal dysplasia is not all that important because, this all just involves the diaphysis, but malariaostosis, osteopodylosis, both of these are exam cases. So these are basically osteoblastic activity. If you go back to the basics, what happens in bone metabolism, that there is osteoclastic and osteoblastic activity. So there is, the osteoclasts are not working very well, and that is why there will be sclerosis. So that is why in generalized bone density, pycnodysostosis comes under that. And once again, hypoplastic lateral end of clavicles, terminal phalanx are hypoplastic. And in adults also, for the simple reason that the same patient will become an adult. So it will be there. And in distal phalangeal destruction, pycnodysostoses is there. So this was, now let's go back to our case. So this was beautifully picked up, very well picked up that, both of the clavicles are missing. And one can argue that there might be slightly hypoplastic glenoid, and so that finding was fine. If you see the ribs, they are, slightly more oblique than normally they are, but this is a very subjective finding. And as far as this pelvis is concerned, again, this thing is hanging. So now you can see it here, that look here, look at the gap, extremely large gap. So that was the finding. Okay, well done. Next case.
Can I ask for remote?
Yes, please.
I have requested.
So what happened was that this is a case of tinnitus and headache, 76-year-old, and they did a IAM protocol MR. In IAM protocol, we have got limited sequences. So this is a T2 weighted sequence from the IAM protocol. Within the IAM, on the cis sequence, there was nothing abnormal. So please see this.
Okay. Yes, sir, I'm starting scrolling. Oh, okay, it is started. So I will take a moment to scroll. This is T2 axial section of a patient with left ear problem. Sorry, sir, I forgot the history.
Yeah, so tinnitus.
Tinnitus, okay.
But you should not be worried about IAM. It was normal.
Okay. So brain so far is, I cannot appreciate any pathology. There are a few prominent Verschurobbing.
Anything in the base of skull?
Sir, I'm going there. In the base of skull, I can appreciate so there is some mastoiditis and
Do you want to see any other sequence?
yes, sir, I want to see T1 fat set post contrast enhanced.
The player for you.
There is there's a significant mass-like enhancement seen around the angle of mandible on the right side, and it is encasing the pterygoids muscle as well as
You meant left. Please remember, this is it is not enhancing, it is high signal.
It is high signal, yes.
Basically said it is enhancing, so I'm just correcting you there.
Okay. So it is surrounding the angle of mandible. The internal marrow spaces have also changed. I'm trying to look for any bony erosion on this, which is I'm not able to appreciate. It is extending into the infratemporal fossa in the masseter. It is also extending into the temporal bone of calvarium. Underlying brain is unremarkable, and there is enhancement in the overlying soft tissue as well. Sir, can I have any other coronal section?
So what is your impression till now?
Sir, my impression is that it is basically a soft tissue malignant, likely malignant process, which is not respecting boundaries and is spreading generally. And but the bone underlying is not eroded. It is quite hyperintense as well. So this is hyperintense on T2 and has some hypointensities on it. It is surrounding the retromandibular vein as well, and I'm thinking of any paragangliomas, schwannoma, nerve sheath tumor.
Okay, what would you like to do next? This
I
was
would
a
like to do.
brain study. I don't have any more sequences for you. This was an IAM study. What would you like to do?
So I would like to see a CT with plain a CT with contrast and plain.
CT. Why a CT?
Sir, just to see bony erosion and if it has some.
So I've got a MR of the neck. Over to you.
Okay. Sir, in this MRI of the neck, this is in the T2-bit sequence, it is quite significantly hyperintense. And it is eroding or you can say extending in through the calvarium into the subdural spaces, but the brain is still looks spared. Moreover, there is, yes, again, it is causing some bony scalloping of the lateral margin of the maxillary antrum. Pterygoid muscles are surrounded by it, but not invaded by it. Bone is also.
Show me the pterygoid
Bone is
muscle.
also does. Sorry.
Show me you have said that they are not invaded, they are surrounded by it.
Sir, at this area?
Okay, just hold on, please. Don't, what is happening here?
Sir, these muscles look invaded and this bone looks invaded as well.
What is this bone? Name the bone, name the muscles.
It is medial pterygoid and it is maxilla.
Okay, what's happening to the masseter? What's happening to the parotid gland?
Sir, it is masseter is involved and the parotid gland. Parotid gland. Sir, if it is, I'm thinking on the lines that if it is lymphoma, as it is surrounding the veins, the veins are quite surrounded by it, but veins
What
don't
other
look.
sequence would you like to see?
So I would like to see. This is fat set, so it is not suppressed on fat set sequence. I would like to see contrast enhanced. T1 fat set contrast enhanced axial.
This is a pre-contrast. I'm just quickly going through it, the pre-contrast.
It is showing some hyperintense signals within it, which means some component of hemorrhage is there.
Okay, then I will show you a post-contrast. This is the post-contrast. Over to you.
There is a contrast enhancement, and it looks that it is involving, it has originated from parotid. This is the parotid gland. And it is quite heterogeneous. Pleomorphic adenoma can be a possibility, but pleomorphic adenoma doesn't invade the surrounding musculature. It is,
So your conclusion, give me your conclusion.
sir, I think it is a primary parotid pathology with the malignant component, and it is invading multiple muscles. It is invading bone, encasing vessels, retromandibular vein. And next, I would see whole head and neck to see its metastasis. And I would also correlate with ultrasound to get a bit more clear picture.
Okay, thank you very much. Can I ask in the chat, anybody has got the diagnosis? Open to the chat. Anybody has got the diagnosis? Anybody has got the diagnosis, please? Low flow vascular malformation. Good, well done. Okay, so let me go through it. So this was a masticator space hemangioma, and people who have written in the chat are absolutely right. Please remember that there is a new classification for vascular malformations, and we have got AVMs, we have got venous malformation, lymphatic. There will be mixtures and things like that. But some or the other, the word hemangioma is still continuing in most of the texts. So whatever you want to call it, it's fine. Both are fine. So please remember that what were the learning points in this case? The learning points was, first learning point was your viewing protocol. When you are looking at the brain MR, please also look at everything else which is visible. And I'll show you on the sequences which we picked up. So in suprahyoid, now in head and neck radiology, the key concept is that what is the epicenter of the mass? And from there, epicenter, where it is going. And you will get marks because of that. First of all, you will get diagnosis because of that. And this was a lesion which was transspatial lesion. So it was going from one, space to second space. But the epicenter was in the masticator space, and that is why it went all the way to the calvarium. So that was a learning point here. Now, if you see here, as far as masticator space is concerned, masticator space is this space which is surrounding the mandible. And these are the muscles of mastication, pterygoids and the masseter. Posterior to that is the parotid. And of course, we've got the carotid space here and the parapharyngeal space here. And slightly more inferiorly, so this is the nasopharynx level. So this is the nasopharynx, and at the level of the nasopharynx, this is the anatomy. Slightly more inferiorly at the level of the oropharynx, this is the tongue. We can see this is the submandibular gland and the parotid. So this also, our case also involved the submandibular space and maybe the buccal space, which is this space. So it was quite transspatial. Key concept about masticator space is that there are few spaces in the head and neck which go and they touch the base of the skull. Head and masticator is a very important one because and many exam cases will be asked because of that. I've shown you many cases because it aberts the foramen ovale And from there, there is a concept of perineural spread of tumors, and infections can go upstairs. And similarly, the what we used to use the word, infratemporal fossa, which is the same thing as masticator space, and lesions can go up. Please remember that dental abscesses can go up through that and will produce subdural empyema and all those things. Our case was a very good example where anatomy, this is the masticator space. And what happened was that our lesion actually went along here. This is the temporalis muscle, and then invaded the scalp and the skull also. So this is the foramen ovale. Now, look at this example from MSK, and this is exactly what happened in our case. This is a what we call a intramuscular hemangioma, intramuscular. Now, if you see here, look carefully and look at this bone, which is the fibula. And fibula there looks like permeative bony destruction. This is a close-up. Do you see this here? It looks like a permeative bony destruction, and you will say that this is a aggressive tumor. Key point is this. What is this key point? This key point is phlebolyths. Phlebolyths are there. And this is the MR, and signal-wise, it is similar, 100% similar to our case. If you see here, these are vascular channels in the muscles. So this is why it is known as intramuscular hemangioma in MSK world. And you can see how dilated, this is a venous malformation, uh, uh, how dilated these are. On a T1 weighted pre-contrast, what happens is that there might be some hemorrhages, and some of the vessels, because they are so big and dilated, they might be slightly high signal. So it will give you, look carefully here, and this is that fibula which is invaded. Now on the stir sequence, you can see that it is invading the fibula. And our case actually did the same thing in the calvarium. So this is the post contrast. This is intramuscular hemangioma, and by the way, one of the points which is a viva point here, which I've taught you in MSK, is that there is a role of Doppler ultrasound. And if this is very compressible lesion, and that is considered very specific. So if you find this lesion, do a Doppler ultrasound. It's a viva question, and you will find that it is compressible and means you have got your diagnosis. Now, this is another one from literature, which is without any further imaging, but phlebolyths are there. Now, let's go back to the case which we saw. Now, so I started with this T2 weighted sequence, and on this T2 weighted sequence, it's a very difficult call, but the but is if you compare right and left, it is not all that difficult. Look at this lesion actually, and look at this masseter muscle. Look at here and so there is a lesion, but it was a bit harsh to expect it to be picked up on T2. But if you ask me, it should be picked up. Then FLAIR actually tells it very well. And on FLAIR, the candidate did extremely well. On this FLAIR, look here that it is invading the mandible. It is superficial to the mandible. Deep pterygoid muscles are involved. Now we are going to the nasopharyngeal masticator space. And here, what we used to call it the infratemporal fossa, you can see it is extending because it is extending into the temporalis muscle. And here, look here, what is happening. This is the diploic space. It has permeated into the diploic space. So please remember that these hemangiomas or slow, vascular venous malformation or slow flow, whatever you want to call them, they can be transspatial and they can penetrate the bones and permeate into it. Does not mean that they are malignant. So this, and interestingly, we have got a CT of this patient. And by the way, this CT was a paranasal sinus CT, and you can see the phleboliths sitting there. Phleboliths were sitting there. Interestingly, very interestingly, this CT was done at another point, and it was done by the ENT for sinus. And I think only the bone windows were seen. These things were there. If you see this coronal, you can see the phleboliths, and these were not picked up. These were not picked up. So, having said that, I could have, in your exam, I could have simply showed you this CT scan. And on this CT scan, which would, there might be sinusitis or no sinusitis, whatever, you pick up the phlebolith and then you make the diagnosis. So, one of the key points in a CT of paranasal sinuses is that on your PACS, soft tissue window will also be sent. People always just, it's a usual thing that you just see the bone algorithm, but you must review the soft tissue window also, though it is a non-contrast. So the phleboliths were there. Okay, next, please. Candidate 2, this is your
Yes, sir.
last. This is a 65-year-old female with abdominal pain. On ultrasound, a large mass was picked up, and CT, chest, abdomen, and pelvis was advised. So chest part is not relevant. I'm just showing you the abdomen part. Over to you.
Okay, sir. Sir, should I request again? It's not scrolling.
Yes.
Yes, it is getting done. So this is CT abdomen, axial section. I will take a moment to scroll. There is some fecal loading seen in the right hemi-abdomen, likely cecum. Just I'm trying to take a moment to get through it once. And I can appreciate a large, solid, heterogeneous, multilobulated, not intensely, marginally enhancing lesion. Lesion is compressing kidney. There are some adjacent vessels as well. And there is a loss of fat pen between the lesion and the stomach bed. There is a splenic cyst. There is some fluid anterior to the liver. In the lungs, so far, nothing is visualized.
Don't worry about, just concentrate on that mass, please. Don't worry about.
Okay. Okay, sir. I will go down. Bones are looking a bit dense. Next, I would like to see the bone window as well. So this is which vessels are these? These are quite encased by the mass, and they are somewhat compressed and reaching till they are branches of portal vein. So the lesion is likely arising from the tail of the pancreas. Sir, can I see the coronal window as well?
First of all, give me your findings on this axial.
Okay, sir, so this is a large lesion which is based in the central part of abdomen, and I believe that it is arising from either pancreas or the stomach bed, because both of the fat planes are lost, and the fat planes are also lost with the adjacent transverse colon and part, which is likely leading to the fecal loading in this patient. And in order to assess its precise location, looks like an exophageal mass, and that much large masses are usually arising from, it can be GIST, exophageal GIST, or it can be lymphoma. So just to see more on the anatomy and its relations.
Okay, here you are, coronal.
Okay. So this is the coronal image, and it is displacing the gut lobes, and it is quite. Sir, can I see pre-contrast as well in the same? Because just to see that the cell.
We don't have a
Sorry?
We don't have a
Mhm.
pre-contrast. What is your question regarding pre-contrast? What did you want to say? See,
So calcifications within it.
Yes, there is calcification in the lesion.
Sir, calcification, it can be a large, but the serous cyst adenoma are usually cystic and they are in the head, but looks calcified. Can it be a large carcinoid? Carcinoid has sometimes calcification and this teething. It is stomach. I don't believe it is arising from stomach because stomach is displaced, fatness are lost, but origin doesn't look from stomach. What about the adrenals? It is not from adrenal, not from kidney. Retroperitoneal space is normally visualized. Spleen.
So, okay, can you conclude? Give me your diagnosis.
Sir, my differentials are that it can be.
If you want to see the axial again, I can show you.
Sorry?
If you want to see the axial again, I can show you, but I just want you to conclude.
Sir, so far I have excluded that its origin is from stomach. So it is either a large mesenteric based carcinoid, or it can be GIST or lymphoma is less. Sorry, pancreas. Sir, pancreatic large exophytic masses. They are rare in the tail region, but solid pseudopapillary epithelial neoplasm, they can be there. Sir, can I see the axial? And I would also like to see bone window.
65-year-old.
It's
65. I told you the age of the patient.
65 years old.
Female.
I will once again go through the. It is going
Okay.
down.
Just 1 second, please.
Okay.
So we are running out of time. Just give me your diagnosis. Here you are. This is the lesion.
Sir, it is pancreatic in origin with calcification.
you to
Next,
give
I
me-
would advise. Sorry?
If it is pancreatic at origin, what is your diagnosis?
Sir, pancreatic adenocarcinoma are usually not that much enhancing, so it is not adenocarcinoma. It can be serous cyst adenoma with some malignant transformation because calcification is associated with that.
Adenomas, do they malignantly transform? Question.
No, usually not. Mucinous has a relation with transformation.
Okay, thank you.
Thank you.
This is a serous cyst adenoma of the pancreas. And serous cyst adenoma in pancreatic tumors, you can have solid tumors and cystic tumors. So we are not discussing solid tumors here. We are just discussing the cystic tumors. 4 of them should be known. Serous cystic neoplasm, which is then SCN, mucinous cystic neoplasm, MCN, intraductal papillary mucinous neoplasm, IPMN, and solid pseudopapillary neoplasm, SPN. Key concept to remember is that serous cystic neoplasm has got a benign version and it remains benign. It does not transform to malignancy. There was a study which came out in France. They did study on 1800 cases, 1800. And that said that out of these eight, became malignant. Later on, people challenged that, and I think these were false positive. So all said and done, take home point is serous cyst adenoma does not transform to malignancy. On the other hand, mucinous cystic neoplasm there has got a benign version which is mucinous cyst adenoma, and there is malignant transformation. And similarly, IPMNs can be benign and malignant, and this one is unique. Pseudopapillary neoplasm, by definition, it is malignant, but it is low-grade malignancy. But clinically, it happens in very young patients. Now, this thing is the key concept to remember. And actually, I told, as a hint also, 65 was the female and 65 was the age. So this is known as grandmother tumor. This is known as mother tumor. Average age is 47. This is 24. So this is very unique. Young, if you see it in a young patient, a cystic tumor, should be worried about this. IPMN average 62 years. Of course, now IPMNs with MR are visible in every second case. Key point to remember in serous cyst adenoma, on a CT scan, the sensitivity to pick up a cyst is not as much as on an MR. So you have to think like this. Look at the outline of the lesion. When you see lobulated outline, some lobulations means it's a serous cyst adenoma. The cyst will be usually smaller, and there can be larger cyst also. And if you do an MR, all of these will be very tiny, tiny cysts. Now, can it be head or can it be tail? This is a usual thing where in my experience, so many registrars, they just think that it can only be in the head because somebody has documented in textbooks that most common head. That doesn't mean that it cannot happen in tail. Please remember. And for me, that is a very bad discriminator. Now, if you see here, look at this picture, and this picture tells you the radiology. This is a classical serous cyst adenoma, which has got a sponge-like appearance. And if you see, just look at the outline, just concentrate on the outline, and you will see it is lobulated because there is a small cyst here, a small cyst here, causing indentation. This is a classical case, which was our case. Usually, you will see calcification in the central part. In mucinous, the calcification will be in the peripheral. How many of them are calcified? 18%. Pitfall. What is a pitfall? Pitfall is that 10% can be oligocystic, so they can have large cyst. Usually, if it is a small lesion, we leave it, but if it is size is more, this one was very large. It was about, I think, 14 centimeter or something like that. So that's why it was removed because of size uh, and age of presentation, etc. Otherwise, we can follow them up. Look at this one on MR. If you look carefully, look at this sequence and you will agree that look at these tiny, 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 tiny cysts. So this is what happens in a serous cyst adenoma. This is on, MCN, mucinous. Please always discriminate it with a pseudocyst of the pancreas. History is important, but in the real world, if the history is not known, this is a very important viva question. So remember this, that when we are in the world of is it a mucinous cystic tumor versus a pseudocyst with no known primary, what we do is we do cyst aspiration, which can be done percutaneous or it can be done through EUS, ultrasound guided, and we check for CEA and amylase. In pseudocyst, this will be low and this will be high, and vice versa in mucinous tumor. So you don't sit on a mucinous tumor. You actually advise the patient either follow-ups or advise if surgery is possible. But of course, in the real world, everybody cannot have surgeries because of age and all those things. So this is a mucinous cystic tumor and look at the calcification. The calcification is in the periphery and the cyst will be larger. What are the signs of malignant transformation of a mucinous cyst adenoma? Look at this case. Here there is a septation which is enhancing. Look here, there is a large soft tissue component which is encasing the celiac artery. There is a portal vein thrombus also. This is a case which initially was mixed up as a what we call pseudocyst, but actually there are signs of malignancy. When you see a mucinous tumor, look at this one. Think like ovary. In ovary, when you find internal thick septations, enhancement, nodules, call it a tumor. Look at, sorry, a malignant tumor. So this is a cyst adenocarcinoma. This picture tells you everything from radiographics, the patterns of IPMN, intraductal papillary mucinous neoplasm. So some of them can be what we call the main duct type. There can be branch duct type and there can be mixed type also. So this is a mixed type actually shown here. This is a main duct type and this is branch duct type. By definition, they should be communicating with the pancreatic duct, but in the real world, radiologically speaking, it's a very difficult call. So this is you see dilated main duct, and if you do an endoscopy, you might find mucin coming out from the ampulla like this. And of course, these tumors also have got, uh, risk of malignant transformation. The main duct type is the maximum. This is a branch duct type IPMN, and many a times it can be multifocal like this, and it can be mixed duct type. Here you can see all of these cysts, and you can see the main duct which is dilated. So, again, if you see enhancing nodules, duct dilatation more than 9 millimeter, etc., it is, signs of malignancy. Look at this one, where you can see dilated pancreatic duct, and you can see here, there is a tumor, and there is a stricture here, malignant transformation. In a young patient, 26, this is a 26 female, this is the daughter tumor. So whenever you find a cystic tumor usually with solid component, they can be large and they can be malignant, but the course is indolent. Okay, then candidate 2. Thank you. Candidate
Thank you
3.
so much, sir.
Candidate 3, are you candidate 3? I cannot find candidate 3. Candidate 3, I cannot find. Candidate 3, if you are candidate 3, change your name. And should we go to candidate 4? Candidate 4, are you ready?
Yes, sir, I'm ready.
Okay. And if I don't get the candidate 3, then
I
I
can
might ask one case each to the previous candidates, anybody who will volunteer. So just 1 second. Okay, now, oh, sorry, I did not describe this case. So let me describe this case. Now, if you see, this is a huge tumor, right? And if you look carefully, this is the pancreas, this is the uncinate process, this is the neck of the pancreas, and then as we come to the body, you can see this claw sign type of a thing. So it is definitely arising from the pancreas and from the body and tail. And then if you look carefully, there are very small, all of these are very small cysts actually, which project like this on a CT scan. And in the periphery, you might find larger cysts. And then there is internal calcification. So please remember, in serous cyst adenoma, the calcification is central. And then look at the outline, and you can convince yourself that it is a lobulated outline. It is a lobulated. Look here even. It is lobulated. Why is it lobulated? Because there is a cyst which is causing a impression, and because of that. The coronal was pathognomic of this. If you see this coronal, you can see, just like the picture which I showed you, that all of these, this is that classical sponge like or honeycomb appearance, classical, and internal, and then internal calcification, and look at the external lobulation. So this one was a larger cyst. So this is a classical serous cyst adenoma. Of course, I can ask you what is it is doing to vessels, etc. It is displacing, but there is no, this is the splenic vein. It is displacing, it is not causing its thrombosis or anything. Okay, now let's go to, again, problem in the software. Actually, it's hanging. Right. Candidate 4.
Yes, sir. Assalamu alaikum.
Alaikum. So I have given you just 1 second. Don't move your mouse. This is a 1 year, 3-month-old female patient, swelling left leg.
Sir, I've been presented with the frontal projection of an immature skeleton of the lower leg representing tibia and the fibula, in which I can see lytic expansile lesion that is involving the tibia, predominantly the diaphysis. Apart from that, a similar first, I would like to describe this lesion. It is lytic expansile, and there is also areas of sclerosis. It is lobulated, and I have a suspicion that there is an evidence of a pathological fracture along its lower extent, because I can see some cortical break here. Apart from that, another lesion is seen involving the distal shaft of the fibula, and it appears more of a permeative lesion with the evidence of cortical thinning and also the evidence of cortical break in this area, and subtle periosteal reaction that is seen along with it. However, there is no involvement of the joints, and the proximal and the distal metaphysis appears uninvolved and unremarkable. The surrounding soft tissues, I'm not able to appreciate any gross abnormality in the soft tissues or any calcifications. First and foremost, looking at the tibia, it appears more of a so the first thing that came to my mind was fibrous dysplasia, looking at the tibia. But hello?
I'm listening.
Yes, sir. But sir, the fibular region appears to be more permeative, going more in favor of an infective etiology. But of course, the two pathologies, it is difficult for them to coexist. But in the presence of fracture, you can suspect a superadded infection. But I would like to refer these findings to the referring physician, and I would like to advise an MR for this patient and also the ortho consultation to further narrow down the diagnosis.
We have got a lateral view also.
Yes, in the lateral view, sir, further there is a Sir, there is a mixed sclerotic lytic lesion, predominantly. There's a lytic lesion with surrounding sclerosis, dense sclerosis involving the diaphysis with evidence of periosteal reaction and bowing.
No, what is your conclusion? Does it change your conclusion?
Sir, features may represent edementinoma, but of the tibia, or
This patient is
1 year old.
edematoma. Okay, so what happened was that
Yeah, there are multiple fractures.
this patient was sent home.
The
Now,
same patient? Sir, polyostotic fiber dysplasia with the fractures come in the first line, considering the age of the patient, and then
why will there be a fracture of the fibula?
yes, sir, there is the fracture here.
Why will there be a fracture of fibula? Is
The pathological,
very rare,
sir,
isn't it? Fibula is
sir,
a
second, sir, second could be osteogenesis imperfecta, but the bones are not very much gracile in this case, but could be.
Oh, chat. You chat. Give me the answer, anybody. FD. Shaken baby. Yeah, one of you have got it. Well done. Well done. Quite a few of you have got it. Okay, let me take over.
Yes, sir.
NF1. So this is what we call, one of the bony dysplasias of NF1, and ultimately it ends up into pseudoarthrosis. So what happens if you see the definition of NF1, if the patient has got two or more than two of the following is the definition. Please remember that these four are clinical, but this is where radiology comes into neurofibromas, two or more or one single plexiform neurofibroma, optic nerve glioma, distinct bone dysplasia. And one of the bone dysplasia is pseudoarthrosis. And this is what I showed you. And in your book, this is NF1. And in NF1, of course, you revise it where, everything, one line here and there will be a case in the exam. It is one of the favorites, and you should have, very clear-cut concepts about NF1. Now, this is from Radiopedia, another example, which also tells you basically what happens in pseudoarthrosis. The bone, usually tibia, please remember, usually tibia, and fibula, number two. Then it can also be radius and ulna. So look at the word dysplasia. So it has got dysplastic bones. The cortex are thin. There might be hypertubulation, and there can be, then what happens is that there can be fractures, and the edges, they become very pointed, and there can be pseudoarthrosis like this. So basic pathology is bony dysplasia. Look at this diagram. So initial bone is like this, then it becomes more gracile. There is a fracture, and it can become like this, and a spectrum of all of this. Look at this one. So I forgot to mention anterolateral bowing. That is important. Look clinically also, anterolateral bowing is there. And this is the case which I already showed you, but just to highlight that it can happen to radius and ulna. Here, ulna is involved. This is a different case, by the way. So the definition is describes abnormal bowing that can progress to a segment of bowing, loss of simulating the appearance of a joint. Usually, they are diagnosed at birth, but rarely diagnosed after 2 years. So please remember this can happen. You might be the first person to seeing it. 80% of congenital pseudoarthrosis is because of NF1, 80% of them. But some of them might not be because of NF1. And 10% of patients with NF1 are diagnosed with tibial pseudoarthrosis, other way around. And other bones can also be involved. So this is again from Radiopedia, and you can read it from there. Bowing, resorption, angulation, cupping, sharpened, narrow appearance, fracture, etc., etc. So many a times this have to be removed, as in amputations and things like that. But usually, just 1 second, let me go through. But usually they manage the fractures. Now, so candidate 4, you should have asked for, once I showed you the lateral, you should have asked for the lateral. And this lateral should have, anterolateral bowing, but so that was the point. Now, this is after 3 years, you can see fractures developing. And then I did not show you, but initially it was managed with, I think till the age of 7, 8, 10, they tried to manage, but ultimately they could not. So that is NF1. Yes, please. This is a 78-year-old female, and they are planning for a brace. So they did an OPG. Over to you.
Yes, sir. I've been presented with the OPG of an old patient in which I'm not able to visualize, like the dentures are not visualized. That must be related to the age. Apart from that, I can see a cyst with the tooth in the mandible, a remnant tooth in the mandible on the left side. Apart from that, the visualized mandible appears appears not unremarkable. I'm not able to appreciate any difference bilaterally. Like they appears bilaterally, it appears the same.
What is your
sir, the dentigerous cyst on the left side.
And where is it?
Sir, it appears to be in the mandible.
Is it the mandible?
Sorry, sir, maxilla. In the maxillary process.
What will you do next?
Sir, I would like to have a CT scan of this patient to see the
CT. Over to you.
Sir, I will request again the country.
Given.
Sir, Australia, I guess. Yes, sir. It is at the it is in the maxillary process at the base of the maxillary sinus. I'm not able to visualize any gross evidence of any soft tissue mass or cortical break. However, there is thinning along its marked thinning and along its lateral margin. And also, sir, I would like to stay to the diagnosis of dentigerous cyst. And sorry, sir.
Can it be anything
else? Sir, less likely odontogenic cyst. It could be odontogenic cyst or a keratogenic cyst, but less likely to be an aggressive lesion.
is there any tumor which can happen with an unerupted tooth?
Sir, ameloblastoma can happen, but it gives more of a cystic bubbly appearance, and it is not also the.
How do you differentiate between a simple dentigerous cyst versus an ameloblastoma?
Sir,
With
ameloblastoma appears to be a cystic bubbly appearance with cortical erosions and soft tissue component, and most commonly it involves more of the mandible, and it is less well defined with aggressive features and cortical resorption.
okay, thank you. So cystic lesions in the mandible or maxilla, the top ones which you must remember for your exam include radicular cyst, which is periapical cyst, basically an abscess with an caries, dentigerous cyst, unerupted tooth, and then please, ameloblastoma. The candidate did well regarding discrimination between ameloblastoma and a simple dentigerous cyst. Please remember both of them. At times, ameloblastoma can happen with an unerupted possible. You see this? What is written here? Possible associated unerupted molar tooth. But the candidate did well. That usually the site is mandible, and then bubbly appearance, so bubble, multilocular cyst, and there will be soft tissue component. One thing is that on this paranasal sinus CT, always ask for a regular window, soft tissue window. Many departments, they do a mistake. What they do is when they send paranasal sinus CTs on PACS, they just send bone algorithm window, high resolution window. So these are very good for paranasal sinuses, but you will miss that. So in usual practice, you must ask for a short soft tissue window. In our case, actually, there was nothing on the soft tissue window. Sorry, I have unshared. So quickly, let's go through it. Now, so these are the 4 cysts. Now, this is a dentigerous cyst, which arises from the unerupted tooth. And our patient was 70, how old was our patient? 78-year-old, planning for for a brace actually. And even then the dentist it was sitting there, otherwise there were no teeth in our patient. And so this is even on MR it has come in the exam, which becomes quite difficult to pick up on an MR. So dentigerous cyst can come in the exam, and the questions will be around how do you differentiate and things like that. This is a periapical radicular cyst where basically there is an abscess or osteomyelitis here. There is caries here and there is a small cyst. Usually these will be small. This on an OPG, you can see that this is a periapical radicular cyst, and look at this, the crown, it has eaten up. This is an ameloblastoma, and this is what I was talking about. This ameloblastoma is, by the way, the cyst has got multiple locules, etc. But look at this bone window. You don't see anything so this is the soft tissue window, and this is what I was talking about. Always ask for this even without contrast. So this is without contrast and this is with contrast. And you can, even on this without contrast, you can see something is happening inside. So if there is a solid component, then you call it. Ameloblastomas, usually mandible, multiloculated, soft tissue component, locally invasive. Recurrent rate is high, and some of them can be malignant also. Another example where soft tissue component here on MR, how soft tissue component will occur. So your case You did very well. It was a simple case. So this is it. And if you see whole of there is not a single alive tooth, but this is sitting very well and must be sitting there since ever. And it is projecting into the maxillary sinus and encroaching on it. Okay. So candidate 4.
Yes, sir.
Now, what happened was that this patient is a 23-year-old male. He was transferred from a peripheral hospital. The patient is delirious. GC, Glasgow coma is low for the last 10 days. And so he is not completely unconscious, but he is in great pain, even back pain. So an MR of the brain and the spine has been performed. I want you to concentrate on the brain only.
Sorry, sir. What's the age? Sorry.
23.
Yes. So I've been presented with the coronal fat sat images of a 20-year-old male person, sir, in which I'm able to appreciate an altered signal density area in the right frontal subcortical region. Similar areas are also seen in the occipital, in the bilateral occipital, posterior occipital regions. So this is most probably parietal. And also going further, it is seen in the right parietal subcortical and the occipital regions. So, sir, I would like, and also I can see bilateral mastoid effusions. I would like to see the diffusion and the post-contrast images. Sir, also I appreciate subtle increase in the T2 signal of the hippocampus, but I would like to further see the other sequences, likely diffusion as well as post-contrast. Sir, DW images of the same patient in which I am not able to appreciate, and there is subtle high signal seen near the vertex in the semi-oval region, bilaterally in the subcortical areas, likely corresponding to the regions which I saw in the flare, also in the bilateral occipital.
Where is it pointed?
Sir, 1 minute. Sir, this area, sir? This
No,
one?
but, you mean to say that there is restricted diffusion there?
Sir, there is subtle high in, sir, if I see this low signal in ADC, I will call it restricted. Otherwise, I can call it subtle edema, because there are certain specks of high signal. Sir, this is the ADC.
Yeah, this is the
Sir, they are not restricting as such, so I can call it T2 shine through.
Okay, so a bit of T2 shine.
There's subtle edematous areas in the bilateral subcortical regions.
Sequence?
So any post contrast?
No, we haven't got a
Okay.
post.
So, sir, my top diagnosis in such case will be Adams or encephalitis. Considering the altered level of consciousness. So I would, apart from that, it can be, I would like to see the post-contrast images to see any associated meningitis as well, and get the history and inform the findings to the referring physician, and
Okay, over to you.
and get an SW. Okay, sir, I'm able to see multiple low signal intensities on the gradient images scattered throughout the brain in bilateral cerebral hemispheres that most likely represent angiopathy or microhemorrhages, cerebral microhemorrhages.
Thank you.
So,
Angiopathy.
sorry, sir.
What do you mean you mean to say cerebral amyloid angiopathy?
Yes, sir. Yeah, sir. Either these are microcerebral hemorrhages or cerebral amyloid angiopathy, sir. But in a 26-year-old, 23-year-old, most probably it could represent, sir, microhemorrhages.
So what has happened?
Diffuse. Sir, I would like to see if there is any history of trauma
There
which
is
might represent diffuse axonal injury, but otherwise these
okay.
microhemorrhages. Yes,
So
sir.
we stop here. Okay,
Yes.
thank you. Chat. Anybody in the chat? The patient is 23. Press vasculitis. Press fat embolism. Lovely. Somebody has got it. Now let me go through it. Sickle cell disease. You see, I am now showing you the same disease with different manifestation, and I did it intentionally. I showed you a sickle cell disease with, with chest, acute chest, and this one is brain part of it. So sickle cell disease, of course, these are the same slides which I showed you previously, and it can actually happen in any part. It can, any part, any system of the body. So remember that. Now, look, just read this slide. Cerebral manifestation of sickle cell disease contribute significantly to overall morbidity. Among the most common causes of stroke in pediatric population. So please remember, if you find a patient of stroke, it can be sickle cell. 25% of patients will have a neurological event in their lifetime. So quite a bit of sickle cell. Now, what happens is that uh, these are the radiological features of sickle cell disease, cerebral radiologicals. So, some of the vessels can be tortuous. There can be stenosis of the ICA and secondary moya pattern. Cerebral atrophy, and you will agree the case which we were seeing, there was a lot of atrophy. He was only 23 years old. And then there can be chronic small vessel ischemia, cortical infarct, but this is what it was. Cerebral fat emboli from bone marrow necrosis, star field pattern. This word should be in your, vocabulary, star field pattern. And there can be, predirect, aneurysms, etc. Press, somebody did mention press. It was a good call, and there might be some stigmata of press going in association. Spontaneous epidural hematoma, rare. Look at this differential diagnosis from Chapman, one of the favorites which I have taught on so many times, microhemorrhages on MR. And these are the ones, acute trauma, hypertensive. Please remember, cerebral amyloid angiopathy occurs after the age of 60, and there is a page of, a pattern for this. Hypertensive vasculopathy, there is a different pattern. In a young patient, multiple cavernomas, particularly in familial syndromes, will be in the differential. But our case was too much, right? And what was the too much? If you see here, sickle cell anemia and bed associated with cerebral fat embolism from bone marrow infarcts, seen in cerebral and cerebral white matter. Look at this word. Cerebral, cerebellar white matter, and corpus callosum. Corpus callosum is one of the take-home points here. And so now, please remember, I can show you the same case vis-a-vis history of trauma type of a thing. And these patients will come with femur fracture, maybe bilateral femur fracture, and there can be fat embolism. So fat embolism, cerebral fat embolism can be because of bone fractures. It can be because of orthopedic or cardiac surgery. Sternum is what we are talking about, sickle cell crisis with bone necrosis. So look at the pathophysiology. microembolism, macroembolism. In macroembolism, a large vessel is thrombosed and you will get findings of stroke. In there are, the clinical spectrum includes headache, lethargy, irritable, delirium, stupor, convulsion, coma. But the radiology is very interesting. So CT, forget about CT, but one thing in macroembolism is that sometimes, just like you get a hyperdense MCA sign, you can get a hypodense MCA sign where fat will be sitting in the MCA. And any examiner has got that case in his or her collection, they would like to show it to you. So remember that can happen. So much fat is there that a big vessel is blocked. So radiological features, macroembolism, same like a stroke. Microembolism has distinct radiographic features. Remember, these are the take-home points. What are you talking about? You are talking about microhemorrhages or foci of restricted diffusion, tiny foci of restricted diffusion, where you bilateral symmetrical, look at this word and take it home, bilateral symmetrical, subcortical, deep white matter, including subcortical U fibers, corpus callosum. This is key finding to remember, and internal capsule. So SWI and DWI are the most sensitive sequences. Now, what happens is that if it is an acute, between 1 and 4 days, you will get, tens or hundreds of foci of restricted diffusion. And otherwise, when it becomes old, then it will become, just like our case, where we were debating, is it restricted diffusion or not? Please remember this patient was transferred after about 10 days or so. And this pattern is known as star field pattern. In our case, star field pattern was not seen for the simple reason that the event was more than 10 days old. But on SWI, profuse microhemorrhages in white matter, including the corpus callosum, we call it walnut kernel pattern. And this is a walnut kernel. And this is from literature. And this is not unlike the case which I am showing you. I showed you. And this is, if you see here, this is the corpus callosum. This is the splenium. This is the genome. And subcortical U fibers, external capsule, internal capsule, everything is involved. So these, look at the pattern, bilateral symmetrical, cortex is involved, cerebellum is involved. And then this is the star field pattern, which we did not see because our patient was more than 10 days old. But this is from literature, from radiology. Look here, star field. And from Radiopedia, this is what star field looks like. So this is, and the same pattern as in, walnut kernel pattern. And this is another example from Radiopedia. So these two, on DWI star field pattern, fat embolism. On SWI, it is fat embolism, walnut kernel pattern. So this is the take-home point. Thank you. Just 1 second. Is the candidate 3 with me? Yes, candidate 3 is with me. So candidate 4, thank you very much.
Thank you, sir.
Oh, I have not shown you the case, isn't it? So in this case, what happened was that in other sequences were not very impressive. I showed you a flare, and there were some non-specific findings. And then if you see, there was a lot of atrophy, and this looks like a 80-year-old, and this is only a 23-year-old. And so atrophy is one of the things which happen in sickle cell. Even here, you look at the temporal lobes, etc., temporal horns. On DWI, we could not convince ourselves that there is restricted diffusion, and that was because of the age of the infarct. But this was the pattern, and if you see here, subcortical, cortical, look at the corpus callosum. It is completely, this is the splenium, this is the genu, and the internal capsule, you see this? Internal capsule is all involved. Quite classical. I did not show you, but we did a MR of the whole spine, and there were acute infarctions, acute infarctions. If you see here, this is a stir sequence, and look at the bone marrow. And that is why the patient was in great pain. So this is, you know, the H-shaped vertebra. This is the double. Look at these acute infarctions. Whole of the spine was involved. So these are manifestations of, so you can get a long case out of this also. Okay, then candidate 3.
Yes, sir.
Yeah, so here you are. Your case.
Okay, this is a frontal chest X-ray of skeletally immature patient. From the first instance, I can see a left-sided upper soft tissue opacity involving the anterior mediastinum, posterior mediastinum, causing a positive, which appears to be not fading above the clavicles, so it's suggesting it's a posterior inlocation. I can see a ribbon-like and thinning of the adjacent ribs. Otherwise, I can't see any obvious lung pathology. No definite destructive sclerotic or lytic lesions. My first of all differential diagnosis would be a posterior mediastinal mass, a nerve sheath tumor, likely a neurofibroma or schwannomas. The first of my differential list. I will convey my finding to the referring physician. I will ask for a chest CT scan with IV contrast for proper characterization and visualization of the lesion. Or okay, this is
You can
uh,
ask the mouse.
yeah, okay, sir. I'm requesting the remote control. Okay, this is chest CT scan, enhanced chest CT scan for the same patient. I'll scroll through the image and I will convey my finding. Okay, there is a soft tissue mass lesion seen arising from the posterior mediastinum with a widening of the neural foramen space and causing a minimal or scalloping of the adjacent rib. The mass lesion is seen to be away from the main vasculature of the aortic arch. no destructive changes seen within the adjacent rib. In my routine practice, I will check the bone window, check, sorry, the lung window. As I said again, I can see a hypotense liver lesion here, which is likely a simple cyst. And my first differential diagnosis in keeping with a neurofibroma, as it's tend to widen the neural foraminal space. In my routine practice, I will also ask for an enhanced dorsal MRI with contrast. I will convey my finding to the referring physician. Okay, this is a T2 axial cuts of the same patient. As I can see, a hyperintense cystic intensity mass lesion seen arising from the aforementioned region with expansion and widening of the neural foraminal space and scalloping of the underlying or adjacent ribs. In my routine practice, I will ask for a proper history if the patient have any previous trauma or traumatic injury.
There is no trauma.
Okay, I will.
So what is your conclusion?
Is there any contrast enhanced images here I can see before
Nothing
I give my
enhanced.
conclusion?
Nothing enhanced.
Nothing enhanced. So
this is the T1 and nothing enhanced.
So this is a cystic lesion. I'm going with a large pseudomeningocele rather than a neurofibroma, as this is a cystic intensity mass.
What is a pseudomeningocele?
It's a cystic expansion of the dural space,
And
or
why
abnormal collection of the CSF through a defect in the dura.
And why does that happen?
Actually, most of the time it's accompanied by trauma or any surgeries, decompression surgeries, like a laminectomy or discectomy. But
Okay, thank you.
Welcome, sir.
So this is pseudomeningocele of NF1. It is not a post-traumatic thing. Post-trauma can never explain what we were seeing in this case. This is NF1, and this is because of dural ectasia. Now, please remember that once again, so I'm showing you a second case of NF1 in this category, and this is the definition which I will not repeat, but you have to have 2 out of any 7 of these. And one of them is distincted bone dysplasia. We have covered pseudoarthrosis. And look at this one, dural ectasia. And our case was actually dural ectasia. And this is, if you read it from Chapman, you can see here dural ectasia with posterior vertebral scalloping lateral meningocele, and in the thorax, ribbon, ribs, etc., etc., notching, etc. So please remember that notching can happen because of rib notching per se is an exam case, which can happen because of neurofibromatosis. And this can be a neurofibroma and it can also be a dural ectasia, superior as well as